Hello, everybody. Thanks for joining the seminar series for AI for mental health. My name is Kilian Pohl. I'm a professor in psychiatry and part of the leadership team. And today I'm very excited to have some of the faculty of this leadership team, three of them presenting their insights into transforming mental health research using AI. Dr. Kaustubh, Dr. Adeli, and Dr. Wiltsey Stirman. Each of them will give a 12-minute presentation about their perspective on this topic, and then there will be a Q&A where you can ask questions to that panel. The first speaker is Dr. Supekar. He is an Associate Professor of Psychiatry here at Stanford and oversees a Neuroscience-Informed clinical research program which aims to use AI to determine variations in the human brain that give rise to atypical behavior and cognition in psychiatric disorders. His talk today will be focusing on the use of AI to derive brain fingerprints of psychiatric disorders. Dr. Supekar, the floor is yours. Stop sharing. Stay. Technology. Flicker. Yeah. Always a problem here. Should I switch it off? No. Sometimes switching off. Well. Okay. Final. Thank you. Can you hear me? Well, thank you, Kilian, and apologies for the technology problems here. I'm really excited to present to you a work at the intersection of AI, neuroscience, and mental health. And I was just telling Ehsan right now, I learned first about neuroscience in this very class when I was a graduate student, almost like 23 years now.
So they used to do like dissections in this room. So it's kind of funny to come back to this class and talk about neuroscience, but from an AI lens. So basically, we all know this is a problem. Mental health remains one of the most challenging, pressing problems of our time. And every year we present the statistics getting worse and worse. And this is just not in the US, it's like everywhere, Initially, it was thought to be just in the US, but we are moving towards a global sort of problem, right? And one of the things about mental health is very few people get access to mental health. And the people who do actually get access to mental health would go to a traditional process of getting some kind of subjective assessments. They would get some diagnosis, could be autism, could be schizophrenia, so on and so forth. Based on the diagnosis, they would get set of treatments, not just one. They are routinely followed. And once it's followed, usually they end up back to the care model. So usually in a lot of medicine, it's like a linear model where you access care, you get better and get out of the system. Unfortunately, mental health, we still have this like a circular problem. And one of the biggest challenges when I first came to this field almost a couple of decades back, and one of the most frustrating aspects of mental health care is, unlike other areas of medicine, mental health care is purely based on subjective assessments, right? You go to a clinician if you're a child who is presenting some symptoms. Based on the subjective evaluation of that child, you might get diagnosed with autism or ADHD and so on and so forth. And as you can imagine, that leads to misdiagnosis, late diagnosis, false positives, false negatives, and so on and so forth. And it's a big problem. The other aspects of subjective assessments is you have treatments which have suboptimal outcomes. And then, unfortunately, there is no way to monitor if the treatments work or not. And then the bigger problem, of course, we have like limited access to care, right? And combined with, the problems which have been happening over a period of, last few decades, where you have increase in prevalence of these psychiatric conditions, and we do not have the mental health which needs to be catering to that big need. So one of the things which we sort of argue, and some of the other people in the neuroscience community and clinical neuroscience community have argued, that we need to sort of use a model of neuroscience-informed mental health care, which sort of involves including information about brain function into clinical care, right? And the idea is, quite straightforward. If you sort of use, quantitative measures such as the brain, it would reduce the reliability on these subjective assessments, and eventually, it's an hypothesis. Of course, we have not reached to that point, but eventually, once we have, because the brain sort of manifests these conditions. So if you use brain function, you can actually improve accurate diagnosis, timely diagnosis, improved outcomes. You could have precise monitoring of outcomes like how we do in other parts of medicine. Unfortunately, we do not do in mental health care. And it would also improve the capacity of the system. And it will also make the system proactive. Unfortunately, mental health care right now is very reactive. When you have a problem, you seek care. But a lot of other parts of medicine, we actually do proactive care, which is like, you have some prognostic model that you might get diabetes, and then you go and see a doctor so that it's much preventable. Right now, that's not the case. And especially when you have a brain disorder, when things have changed a lot in your brain, it's very difficult to reverse the effect in your brain. So this is what we hope for, and we've been hoping for now almost a couple of decades. And many other people in the world also have been thinking about this. One of the biggest challenges in sort of addressing this problem has been we just do not have a good understanding of what are the brain mechanisms underlying psychiatric disorders, right? And why is that the case? It's not like we do not have enough resources. We have enough resources, we have enough manpower. One of the biggest challenges has been like, kind of research we have also done is small sample sizes. So typically, if I want to, for example, study autism or schizophrenia, I apply for a grant to NIH. We scan children, and it takes like a few $1 million. And we scan around like, in 5 years, almost 60 to 70 children with autism, for example, right? And that's unfortunate because what has happened is, after 5 years, you publish a finding, and someone in the UK or Germany or some other place would find completely opposite. And the problem there is because there's high heterogeneity in all these psychiatric conditions. And we just do not have enough statistical power to detect these conditions. And the other sort of interesting aspect of psychiatry is, if you look at neurological disorders, right? If you have Alzheimer's, you can look at the brain scan and there will be a hole in the brain in your hippocampus, for example, right? Unfortunately, in conditions like mental health disorders, the brain changes are very, very subtle and very, very complex. So conventional analytical methods which people have used just don't work, right? And people have been frustrated, almost for a couple of decades about this problem. And so what has now changed? What has changed is we now have these NIH-driven and all kinds of other data sets. We have access to large amounts of data, which people are sharing across the world. And NIH has made mandated to share some of these data sets. And along with the same time, we have access to this data. And we also have new algorithms, which allows us to sort of access or have the possibility of looking into these conditions in a much complex way, right? And so what we have done in the last few years, we have used some of these data sets, some of the ones which we have also collected, and conducted a series of AI-driven studies, right? And we have access to, we have looked at, so for example, markers of different conditions, autism, ADHD, schizophrenia. We have looked at different kinds of treatment response, for example, schizophrenia. We also looked at predictors of response to treatment for ADHD and depression. Also looked at prognosis of psychosis so that we can have proactive care, right? So in the interest of time, of course, I won't go into each and every study, but just to give a flavor of how we're approaching this problem in a new transformative AI-driven way, I focus on one study which we did a couple of years back. The idea was to look at autism, right? And autism is specifically of interest. As many of you know, autism involves two aspects of conditions, social communication impairments, as well as restricted and repetitive behavior. And, I always see this thing, almost, there's no other condition in psychiatry where the prevalence has increased so much, right? It has increased in the last 2 decades by almost 300%, right? Unfortunately, as I mentioned, autism is still diagnosed using completely subjective assessments. And because of this subjective assessment, there's a huge percentage population which are either misdiagnosed, late diagnosed, or not diagnosed at all, right? And these individuals are not captured in the statistics, and they are not getting access to care, right? So the idea is, can we use sort of brain-based markers to accurately predict diagnosis of these conditions, and then also predict what is the severity of this condition, so that we move to objective measurement-based care, which Killian mentioned. So the focus was pretty simple. Can we identify brain signatures, and essentially using large-scale data, which we have access to, and recent AI advances. And so what we did was we collected data from more than 2,000 individuals with autism, spread across almost 29 international sites, and we developed new AI algorithms, specifically deep neural networks, to sort of look at functional MRI data, which basically means that it's measuring how your brain activity is changing as a function of time. And then the system or the AI algorithm would basically extract meaningful information, in this case, spatiotemporal brain dynamics, which distinguish between the two groups, right? So this was cool, it's a very, very new approach. It was conducted. So the first question to ask is, how do we know if this thing works? What I told you is one of the biggest challenges is the subjective assessments. So it's quite possible that the people who are labeled with autism are not even autistic, right? So if you're developing an algorithm which is based on human labeled data, you're basically, it's a chicken and egg problem. So how do we even know whether something like this even works? So we need to first test this model, right? And we thought about different approaches. We thought about, you could pick psychiatric conditions, but none of these psychiatric conditions, all of them have problems with subjective assessments. So one of the places where we do not have problems with labeling someone, less problematic is gender, right? So if you take males and females, and the idea then was, if you want to test this model, we want to first take data from males and females and ask this algorithm to basically predict whether that person, just looking at their brain scan, whether there's male or female. And so we went ahead and did this study. We looked at almost 2,500 males and females. collected across the US, Germany, China, all kinds of places, and asked this question, can the algorithm do that? And we published this paper last year, and almost with more than 90% accuracy, you can predict just by looking at the brain scan whether whether you're a female or a male. And what we'd also tested was, can we basically scan anyone outside where the data has been trained from, where majority of these algorithms fail, completely in a evaluation of the system, and ask the system whether it works very well, and it did. It's almost like 89% accuracy. So in the training data, it achieved almost 90% or 94% in some cases, but in the testing, in a completely new independent data set, it worked very, very well, almost 89%. And so that gave us some thing about, oh, this is working, let's try this on autism, right? And as I mentioned, we spent almost 3 years collecting this data across different consortiums. And then again, we did the same thing. We trained and tested. And so what we observed was the system did very, very well in the training sample, as well as in a purely generalized sample. And the model, the AI-driven model, in this case, deep neural network, completely outperformed almost every other model which had been used previously, which actually tells the story that conventional analytical methods are not good enough to capture this data. And one of the things we want to capture is, if you want to really use this in the clinic, the clinician is never going to ask whether the child is autism or not. Almost 60% of children with autism have ADHD. So you want to have differential diagnosis, right? So all these individuals did not have ADHD, right? So what we wanted to test is the system should predict autism, but it should not predict ADHD, right? If you really want to implement in the clinic. And we actually observed that the system did pretty terrible in actually differentiating between ADHD and typically developing controls, right? So this is great. It gives a value. It's accurate to some degree. It's not as good as gender, but it's a good first step. And the next step we wanted to ask is, what are the underlying brain mechanisms driving this? Because that's very, very important. So we basically use explainable AI to identify brain systems. And one of the most fascinating things what we observed was we found consistent signatures across different cohorts. And one of the best things, which if you look at the literature of last 30 years of autism research, these were the brain regions which are implicated in autism. And by using a completely data-driven, hypothesis-free approach, essentially everything converged on what we know from the last 30 years. And that was, as a neuroscientist, that was a very good thing. Because we know that classification can come from the visual cortex, but visual cortex is not involved in autism, right? So regions which came up were involved in social cognition, social communication, restricted and repetitive behavior, which are the core hallmarks of the disorder. And we were also able to predict symptom severity using this approach, right? So essentially what these studies are providing, what we have done, other people are starting to do is, are moving towards neuroscience-informed. It's a first step, of course, but it actually shows transformative potential of AI to sort of advance our neuroscience-informed solutions for mental health care. Again, I said, this is the first step. We need to do more. We need to refine models. We need to integrate other kinds of data, which Ehsan and Shannon is going to talk about, different modalities, not just brain imaging data, but can we add for structural MR data, behavioral data, so that we have better, how do we integrate into clinical workflows, and of course, ensure equitable and ethical solutions. I want to thank colleagues, and of course, I'm more than happy to take questions at the end of the talk. Thank you.
So in the interest of time, I'll keep the introduction of the next speaker very short. It's Dr. Ehsan Adeli, who is Assistant Professor in the Department of Psychiatry, as well as has appointment by seeing computer science and in biodata science. He will talk about ambient intelligence and multimodal sensing for detecting behavioral markers of mental health disorders. Yes, thank you so much, Ehsan. Here.
All right. Bondage. Seems to be hard now. Hopefully the mic is working, and great to be here. So thanks for the intro, Killian. And I wanted to say that when we were discussing doing this presentation, this talk, I was thinking of different topics because we do have a couple of relevant projects that could be great to discuss, but most of those take more than 12 minutes to discuss. So I decided to start with one of our ongoing projects and tell you what we are doing in this space, which is ambient AI for mental well-being. So let me get started with this story from Psychology Today. This is the story of Kinga, a university student who had shortness of breath and would suddenly get anxious, and she always also experienced irritability. Kinga was diagnosed with asthma. Despite asthma treatment, her ability to catch her breath persisted and nothing changed for her. She explains, sometimes I would scream at my parents or siblings over the smallest things. My mom calls it being a teenager. She didn't realize, none of us realized, that it was more than that. This story highlights how changes in how challenging it is to detect symptoms and how self-reports are actually incomplete, inaccurate when it comes to reporting mental health status. Another story published by New York Times a while back looks at another angle of this, but this time in older adults. This story from New York Times highlights that memory loss isn't the only, or in many cases, the first sign of dementia. And among the early signs, I'm not seeing most of, okay, now should be good. Among the early signs of cognitive decline, there are different personality changes listed, as well as sleep disturbances, which are often referred to as neuropsychiatric symptoms or NPS. And these symptoms are also often stigmatized and are not even reported in many health wellness visits during Medicaid visits, annual wellness visits. So these two stories highlight the need for better measures, which I'm referring to now as passive monitoring. Traditional reliance on self-reports and even caregiver observations may miss early signs and key markers. And this is a call for implementing passive contactless sensing technologies that can aid in early detection and also in intervention. And to this end, I would like to introduce to you a technology that we're working on called ambient intelligence. Ambient intelligence is the element of a pervasive computing environment that enables physical spaces to interact with and respond appropriately to the humans in the environment. This capacity is enabled by unobstructive embedded devices in the environment, sensors, and natural user interfaces that ensure context awareness, providing some services autonomously using artificial intelligence in response to perceived needs. I'm seeing some movement there. The screen was not shared, right? It was? Okay. Okay. So with this technology, we've been working on a few projects, and my vision was to endow healthcare spaces with ambient intelligence via smart sensors, computer vision, and machine learning algorithms in daily living spaces. We look at activities of daily living, behaviors, and relate those to health, monitor health, and intervene. We also implemented this in hospitals. We worked with the Stanford Hospital. I'll show you some of the results, and other healthcare environments by providing physical spaces with sensing technologies. These spaces include different use cases. I'm listing some of those here, but the core to all of these applications are methods for detailed understanding of human behaviors and activities. And that's why I've been partnering with the hospital, Stanford Healthcare and Clinics, Clinical Excellence Research Center, researchers from Human-Centered AI Institute at Stanford, and the partnership in AI-assisted care, where we first tested this type of technology in a more technology-friendly environments like hospitals. We tested this in Stanford Hospital 500P. We used custom embedded hardware that has different sensing technologies. We use depth, RGB, and thermal sensors, as well as edge computers to just run some lightweight AR algorithms. We installed 2 of these sensors on the bed foot in 8 ICU rooms and some of the hallways connecting those in 500P. And just recently, earlier this year, our paper was published using this infrastructure and all of the analysis for understanding the clinical behavioral, what we call clinical behavioral atlas. If you're interested, I think this paper could be accessed online now. To develop this model and the technology, what we did was we used over 1 year of data from 8 ICU rooms. Each color is a patient, and the technology enabled us to understand generally the position of the patient personnel, some of the attributes around them, as well as understanding, for example, the type of activities that is happening around the patient, centered all of the bedside activities that is for delivering care to the patient. And in addition to that, there has been several other components that our system was able to detect, including the diagnostic procedures, therapeutic procedures, and all of those devices. So this was more of an observational study, which basically gave us the power to create these descriptive analytics around patients' functional status, behaviors, and actions in the rooms, and then even device usages and so on. Although this is right now just observational, we are now implementing this, helping some other researchers to use this in documentation practices in the hospital, as well as future studies for this work are aiming at quality improvement, intervention and quality improvement. So with that, we've always had this question, can we develop reliable methods to detect some early indicators of behavioral impairments, mental health, psychiatric symptoms at home, which I actually started with because of the subjectivity of the measurements, this technology could help with bringing that objectiveness to measuring behaviors. And as I started with, one of the use cases that we've looked into was neuropsychiatric symptoms, which are, again, early signs of dementia in many cases. And as it's shown in prior work, there has been great evidence of some of these subsyndromes of NPS being early predictors of even preclinical Alzheimer's disease and amnestic mild cognitive impairment. So with continuous contactless automatic in-home health monitoring systems, this project is aiming to detect triggers and repetitions of NPS, neuropsychiatric symptoms, and the outcome will be developed into, is right now being studied, developed into a clinician interface linking outputs of the AI systems to clinicians' needs. So far, we have been able to collect data from 19 participants, age ranges 67 to 92, average of 80 years old. Over half of the participants are female, and the study period is one entire month, where in the beginning we run TICS, the telephone interview for cognitive status, as part of the screening, and from the older adult. And then after they are enrolled, we look into MPIQ, Neuropsychiatric Inventory Questionnaire, MBIC, Mild Behavioral Impairment Checklist, AES, the Apathy Evaluation Scale, as in the beginning and the end of that 1 month of time. And every single week, we also have a questionnaire, SAM, self-assessment mannequin, which is a picture-based pictorial assessment of mood and emotions. So from the participant themselves. Okay, with that, this is the type of scene or what we see from the homes. Again, because of privacy, we can't show any of those videos, but this is showing an older adult and the family member. Family member is helping the older adult do some exercises, but these are the type of actions and activities that could actually be detected all through with the system. So while we are still working on analyzing the data, let me just tease you a little bit, share some early results with you. And here I'm visualizing results of the computer vision processing of 2 participants. Let's call them person A and person B for the sake of anonymization. And based on NPIQ responses, we know that both of them, they have high levels of depression. I'll have one more minute. And we can see that person B here is showing high daytime bedding, whereas person A shows high daytime sitting and walking, a lot of agitation. And interestingly, both these two types, these two participants are highly depressed based on NPIQ, but they have 2 different types of behaviors, basically hypo and hyper activities. So this is probably quantifying or giving us some sort of measurement on how to even understand the subtypes of depression. So there are so many other interesting results that we'll publish soon, hopefully in a manuscript. Before I end, I want to say that yes, privacy is probably in the mind of every single one here. Privacy is a challenge. This has been something that we've been looking into pretty much. That's one of the solutions that we are proposing here is bringing all of those ML algorithms and detections that I talked about to the edge device, edge AI at the edge, so that no data is leaving this device. Everything is hopefully processed here. No data transmission means more privacy. In addition to that, I saw Nicole here, we had a paper published by Dr. Martinez-Martin. As a group, we published guidelines for privacy and ethical aspects around ambient intelligence. I would suggest looking into this if you are interested. Finally, this whole story that I told today was actually part of an article that was published by HAI and also Stanford Momentum magazine, if you're interested. Again, it's easy to find it online. At the end, would love to thank all of my amazing collaborators who contributed to this project and what I presented today, and the amazing list of students and postdocs who are right now working on this project. And again, thanks for listening. You can find me on LinkedIn and Blue Sky.
Thank you so much, Dr. Adeli. So
do you want to introduce it?
Yeah,
Can we find?
it's okay. Just in the interest of time. So Professor Wiltsey Stirman is presenting next. She's a professor of psychiatry as well as part of the VA, and she will talk about using large language models to support implementation and quality of evidence-based psychotherapy. Thank you so much.
Trying to bring up.
Okay, thank you everyone for coming. And thank you, Killian, and everyone who was involved in setting this up, HP. And great, thank you. Okay, oh, I'm used to a touch screen.
It is on.
Okay,
that's such
perfect. Gotcha. Okay. All right. So I'm going to look kind of further out on the translational spectrum. So we're going to be talking about taking interventions and how AI can support the use of evidence-based interventions in routine care settings. But before I do this, I want to acknowledge that there are a lot of questions around, well, you know, when are we going to be using AI chatbots as therapists? You know, how soon are we going to get there? And the answer is it's already happening. There was a clinical trial published recently for mild to moderate depression and anxiety that looked promising compared to wait lists. So it is happening. And our group is looking at some aspects of that, but we're really advocating for a bit more of a phased approach. But I think there is a place for AI in terms of supporting mental health and supporting evidence-based intervention, because we know that as many treatments as we've developed, we have a huge implementation gap. Most people don't actually have access to these treatments, and that we need to be looking at things like, how do we get these treatments out there? How do we train and support therapists, providers, peers, people who might be able to provide these treatments? And we need to acknowledge the reality that people are already using AI for therapy. In a recent survey that some colleagues and I did, that Betsy State is leading, 24% of individuals in a nationally representative sample of people who are using the internet said that they had used LLMs in some way for mental health. And one of the things that they were trying to deal with is access to care. They found it difficult to access care for reasons including cost, insurance, availability, timing, et cetera. So what we're doing out there is not meeting all the needs, or it's not reaching people. So at some point, I think we are going to see a lot of innovative uses of AI to supporting mental health. And we are going to see ways that people are using AI for psychotherapy. But in the short term, they're not performing like therapists. So this is a study that I did with some colleagues who we compared prompts. We took some standard prompts and we gave them to chatbots, and then we gave them to therapists. And the therapists responded very differently than the chatbots did. And then we asked the therapists to critique how they were done. So the therapists were much less verbose. The chatbots, particularly the more assistant type things like ChatGPT, were just so wordy. And it was a lot of explaining. It was sort of bot-splaining. It was not, it wasn't really as therapeutic, although they did a good job with empathy. One thing that made a big difference is they didn't do that much assessment. They didn't ask questions. They didn't try to find out more about what was going on. They tended to validate and then jump into some sort of advice giving and suggestion. And sometimes that didn't really take the cultural context into account. Sometimes the advice that they gave wouldn't really work in certain cultural contexts. So that was something that the therapists definitely noticed when they critiqued the nature of their responses. Although they thought that the validation and empathy was good, and there have been a lot of papers out there showing that you can train chatbots to support and train providers and telephone counselors and crisis counselors to be more empathetic, and that people experience good therapeutic alliance with these chatbots, that they really aren't responding in the same way. And there were concerns as well about how they handled risk. And also the broader concerns about whether people would become kind of dependent on these. But the real question that we're trying to answer is, how do we actually make therapy better with AI? So if we think about the way that, we've all seen the self-driving cars around here, for those of you who have been out here for, a decade or more, you probably have noticed the phases of development where initially, there's somebody in the car, the hands on the wheel, the human's driving, and the technology is learning from it and maybe supporting. Maybe, there's some navigation and blind spot detection, things like that. And then over time, it started actually driving. Humans' hands were on the wheel. The human could override if they needed to, but they weren't actually, there was still very much a human in the loop, and then fully autonomous. So we're thinking about this with therapy as well. Initially, there might be use cases for something like a large language model to do things like provide psychoeducation, to help with things like activity planning for behavioral activation, for depression, looking at things like behavior logs and sleep logs, and maybe even doing some summarization of them. But the therapist it's really still primarily a therapist and patient interacting, and the LLM is providing some sort of assistance. Next would be more of a collaborative phase where maybe the LLM is administering and scoring assessments, or maybe we're using some sort of AI to actually assess more reliably. Maybe it's providing some of the steps of a manualized therapy, and the therapist is kind of monitoring to make sure that these things are going okay. Maybe that's something like a CBT for insomnia, and the LLM and the patient are interacting, but there's a therapist who's checking in to make sure things are going okay. Also, for people who are doing CBT, the worksheets and the practice between sessions, there could be real-time feedback and support, so people don't have to wait a week. I'll talk more about that in a moment. And then at some point, we might reach fully autonomous, where the LLM is actually assessing, conceptualizing, delivering interventions, assessing change, and adjusting accordingly. But until we get there, our group has really been focusing on implementation questions in the shorter term. Everything from supporting therapists in planning or supporting implementation of different treatments. When you learn a new treatment and you're trying to integrate it into an organization, there are a lot of things that you need to do besides just train the providers to make sure that it's successfully implemented. So we've got a prototype of a chatbot that helps with implementation planning and support. I'll talk today about training and supporting therapists, and then moving out to the end of helping patients, supporting them between sessions, supporting them with some of the new skills and things that they're practicing and learning. So I'm going to very quickly go through a couple of examples. That arrow should be over in the assistive AI section. This is a project that I'm doing with a group here at Stanford and some collaborators who you'll see again and again in some of this work I'm doing. But we're doing a messaging-based therapy for post-traumatic stress disorder, and we're using large language models to actually label and code these transcripts for fidelity, to determine whether or not the therapists are sticking with the protocol, to look more broadly at what's happening in the session, so we can really learn about optimal levels of fidelity, if any other things are happening that we should know about during the sessions that might be predicting symptom change, et cetera. So that's one approach that we're using, and that kind of falls more in the assistive, because then we can summarize what's happening, see it at a glance, maybe get the therapist feedback. So at this point, we are, we're running it, we're comparing it to human raters, we're looking at how good of a job it does and how reliable it is. Another thing that we're doing is training therapists and using simulation and feedback. This is a use case we're seeing a lot for large language models. So we're training therapists in evidence-based treatments because we know that you can't just give someone a workshop or a manual and expect them to go out and be able to do the treatment. And the more practice they get, the better their first cases do. We've got some data showing that people's first case doesn't do as well as their second, third, fourth, et cetera. So what if we could let people practice with chatbots before they actually get out there? And what if we let them practice some of the things that they're anxious about, higher risk situations, et cetera. So we've been simulating patients using written exposure therapy, which is a brief treatment for PTSD that's got a good evidence base. There's a lot of interest in using it in primary care, et cetera, because it's only about 5 sessions and gets good results. There's interest in some work on, peers and non-licensed professionals doing it. But there are only about 20 people who are trained up enough in written exposure therapy to be able to do the training and support. So this is the team we're working with to actually do this, and we've got voice integration happening. It's in the works. We should have it soon. We weren't happy with an earlier version where we tried it out, but essentially you can see they're simulating what they would do in the session, and they're getting feedback as they go over on the right. And then they're also being able to track whether everything that's happening in the session is supposed to happen. So we're planning a study where we compare that to the typical kind of consultation after training to see whether it's non-inferior or whether it's something that could at least replace part of that and get people ready to see ready to treat their patients more confidently sooner. And we have a little bit of data suggesting that people who are exposed to this might have started getting cases and actually, working with people a lot sooner than we see people usually get cases after workshops, like within a week instead of a month or two, where they sit in consultation for a few weeks before they actually start it with their own cases. Last thing I'll just share very briefly is supporting clients between sessions. This is the team we're working on for this, where we are, we want to enhance the quality and the engagement with homework, because we know that when people practice between sessions, they get better outcomes. But whether or not people actually do it is pretty variable. A lot of people don't do that much work between sessions. And one of the challenges is when you're doing something like a cognitive behavioral therapy, these worksheets, there wasn't really a user-centered design process. These things were developed like in the 60s and 70s, and the best we could do is a piece of paper and some graphs and grids. And when we watch people do, now we have them on apps, but when we watch people do them and did some user experience, we saw that people weren't really correctly, doing each item, that they wanted some help. And that what we had in the app wasn't sufficient. So we're developing a chatbot that actually gives people feedback and guidance when they're stuck. And what we're testing to see is whether the quality and the quantity goes up, and ultimately if we'll see better outcomes. So this is what the CPT coach, CPT for post-traumatic stress disorder, this is what the app looks like now. When we integrate the chatbot, you can see it's giving feedback and support. And people can turn that on or off and just use it when they're stuck if they need. And then finally, I just want to show that there is this example that I alluded to. This is not our group, but another group has done one of the first randomized controlled trials of a fully autonomous CBT large language model, again, with kind of mild to moderate levels of depression and anxiety. So this is a first step in that direction. It's definitely going to be happening. And I think that some of the work that we've been doing with the LLMs are helping us with building blocks. Like, how do you actually provide somebody with feedback? The supervisor that we're using on the LLM knows what needs to be happening clinically, right? It's been trained to detect what's happening clinically, and if it's happening correctly, it's giving the therapist that feedback. At some point, we could cut that out of the loop and make it an LLM therapist. But we want to make sure that we're doing it responsibly and a phased approach, and that we're evaluating for some of the things. This is work that Jane Kim worked with us on, and some other folks in our group, to really think about how we need to look to see if these things are ready for deployment. And so we want to look at factors like safety, privacy, equity, is it as free of bias as possible, and fitting with different, people from different backgrounds. Is it effective? Are people engaged appropriately and not too engaged and dependent, but engaged enough to get what they need out of it? And then when we develop it, we want to make sure we can actually deploy it in a way that it fits with workflows and systems. So if we develop it, but it can never be integrated into the healthcare system, then we're not really doing much. Or if it's something that people couldn't adopt and use on their own. So we're looking at readiness for implementation as well. And I will stop there. But feel free to reach out if you want to learn more about the work we're doing. And thank you very much.
Thank you so much.